Hello, everybody. My name is Borna Bonakdarpour. I am an associate professor of neurology at Northwestern University Feinberg School of Medicine, and I'm the director of the Northwestern Music and Medicine program. I direct the program together with Clara Takarabe, who is the co-director. I wanted to talk to you a little bit about, the work we've been doing here in Chicago in terms of music interventions for neurocognitive disorders. Here are my disclosures. And so we're going to talk about some of the, I'll show you a video first, and then we're going to talk about some of the basic principles of neuroscience of music, and then we're going to delve into neurocognitive disorders. So I'm going to show you this video. I'm sure we have a mixed audience. Some of you might have seen this video, but it's so impressive that I think it would be nice to play it one more time.
See Henry inert, maybe depressed, unresponsive, and almost unalive. Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression. His eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music. The philosopher Kant once called music the quickening art, and Henry is being quickened. He's being brought to life.
Yeah.
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay?
Do you like music?
Well, I guess Cab Calloway was my #1 band guy I like.
So this is one of the many examples of how music works in people with neurocognitive disorders or neurologic disorders in general, where you have regions in the brain that are intact and they're responsive to music, and then you can use them to improve quality of life, to use it for rehabilitation, to improve, for example, hospital stay. So this is really what has been motivating us to be in this field.
See Henry.
And we're going to talk about a little bit about the neuroanatomy of sound and music processing to see, what happens when we listen to sound, and then what happens in dementia patients or people with neurologic disorders, and how can we help them using music-based interventions. As many of you might already know, music processing starts from the cochlea in the inner ear, and then you have multiple stops for the signal to get to the surface of the brain. And this puts sound processing at a very unique position, because compared to other senses, there's a lot of modulations that happen at many levels, subcortically, below the cortex or surface of the brain, until the signal gets to the brain. And which means there's a lot of room for interventions at many levels. And as you see here, some of the reflexes or pathways just originate even before the signal gets to the cortex, before we consciously hear something. Here inferior colliculus, you see there is a feed towards the spinal cord, and that's, for example, the reflex when we hear a loud voice and then we turn. And then that's exactly another thing that can happen. For example, when you hear a rhythmic music or a calm music, some of the initial autonomic responses to the music happen subcortically, even before it gets to the cortex. Some people in the neuroscience field think we sometimes have an emotion related to music because we feel its effect on our physiology. And of course, we have the emotions after the signal gets to the cortex. From there, from brainstem, the signal gets to the auditory cortex, and then from there, a very important area is the medial or inside part of the frontal lobe, where you have the cingulate cortex, you have the orbitofrontal cortex. These areas are related to processing of emotion and social interaction. And this was mostly in the inside of the brain, in the medial or inside of the brain. Now, if you look at the outside of the brain, eventually the signal gets to the auditory cortices, primary and secondary. As you see here, they are within the sylvian fissure, and from there you have two streams of pathways going towards the spatial processing, where we know where the sound is, and also towards the motor areas of the brain. We all move with music. That's a very inherent thing in our brain. We are wired for it. And then also the signal gets to the front part of the brain, the premotor and prefrontal areas, where you have music tapping into the executive function. So as you see, music can tap into a lot of our cognitive functions, and therefore it's eventually processed in the whole brain. And then one of the major principles that we use in music-based intervention is the fact that our brain phase locks with the music, with the rhythm, not only with the rhythm, but also with the ups and downs in the melody, in the melodic line. And then this affects your breathing rhythm, your walking rhythm, your heart rhythm, taps into the autonomic nervous system. What's fascinating is the tension and release in the music. Music, like language, has phrases, and then you build up. The musician, the composer, builds up this tension and release to engage the attention of the listener. And as you see here, the sound analysis in this study, as it goes up and down, you have the tension and release. You can see the same synchronization in the brain as well. And we have this inherently, it's wired, we are wired for it. This is my son at age 1, moving with the rhythm. So, and that's one of the reasons, because music is so much ingrained in our brain, is when we have some neurologic disorder that affects parts of the brain, a lot of what is related to music is preserved. And that's why we can use music for improvement in quality of life or for rehabilitation, as I showed you in the first video. As a therapeutic intervention, music has been known to be effective for medical purposes, for psychiatric purposes, from very, very early on. There are written evidence for it in the Bible, in the mythology. One of the first people who talked about the effect of music was Plato, in the classic era, where he mentioned that music is an integral part of daily living, and to achieve justice, we need to have music and music performances to have a just and healthy government and governance. He also talks about rhythm and how it's linked to internal order and self-regulation. In Laws, he talks about how rhythmic rocking and singing of the mother helps to soothe agitation in the newborn or infant. Fast forward, music became clinically relevant in the clinical world after World War II. The National Association for Music Therapy was formed in the 50s. You can see this in the hospital music newsletter here. And so it was always part of the clinical interventions. What was lacking was the, knowing how it works, doing clinical trials. And in that case, a lot of medications grandfathered in without clinical trials, but unfortunately music didn't. So that's why insurance companies now are not covering music therapy. And, it's our duty to kind of show the efficacy of music interventions and also show the mechanistic underpinning of music interventions, so we can convince the insurance companies and our colleagues who are not familiar with music interventions as how music can be one of the choices for management of different patients in different areas of medicine, including neurology or psychiatry. In 2000, JAMA, Journal of American Medical Association, had a report summarizing some of the clinical trial efforts that started happening in 2000, looking at different neurologic conditions, psychiatric and medical conditions. And to me, I was graduating from medical school at the time, so that was very promising. We have a lot of music therapists, more than 8,000 music therapists and about 1,000 music practitioners in the United States. They are really underused. And I'm hoping that by the research we are doing, we can increase the awareness in this area, so we can kind of combine music therapy in the management of patients. And again, some of this might be already known to some of you. I included it because maybe some of our audience may not know these details. Music therapy is when a credentialed music therapist administers the music. So not everybody can do that. There has to be some training and certification. If we use music for research purposes with the research questions, it's called music-based intervention. It's for experimental protocols. Music medicine is when music is used for health promoting goals. And music supported therapy is when music is used in combination, for example, with physical therapy, for example, for rehabilitation of hand weakness or paralysis in a stroke patient. And fast forward, 2017, this paper came out in Lancet, looking at those clinical trials that I just talked to you about, and then showed some promise in some of the music-based interventions in neurological rehabilitation. In the same year, we had the first session on music and dementia with our own Jolene Johnson being one of the presenters, and it was very hopeful to see that the field is now much more revived. During the same time, NIH and Kennedy Center, with the support of Francis Collins, the head of NIH at the time, and Renee Fleming, as you know, started the Sound Health Initiative and Sound Health Network. At Northwestern, we had our first music therapy conference in 2018, where we got to meet a lot of leaders in the field. And NIH started, webinars and training sessions online and through written communications. Renee Fleming, during the pandemic, worked with a lot of people, neuroscientists in the music-based intervention field and music therapists, with some podcast interviews, which was published 2 years ago as Music and Mind. Daniel Levitin published his book about 2 years ago on music and medicine. And one of the major progress in this area is the networks through NIH, with 3 networks related to pain and music, and one music and dementia, which we are part of. And now with that, let's talk a little bit about music interventions in neurocognitive disorders and dementias. This was my first exposure, hands-on exposure with music-based interventions through melodic intonation therapy when I was a medical student, and I did a study in Persian language to see if in patients who have severe expressive aphasia or primary apraxia of speech, whether you can help them speak better using music. What had been done at the time was in Boston University, whom I started collaborating with, they had shown that these patients, although they can't talk, they can sing. And then if you use the singing to help them say words and phrases over time, after many, many interventions, many, many days of intervention, they can actually improve in some of their expressive abilities. The way the music works is very easy. You use 2 pitches up and down to follow the prosody of the phrases and sentences. Let me show you an example here. This is a patient who can't really say anything meaningful, but he can very easily recite phrases.
Hello, hello, I am juice.
He can sing with unison, then the therapist withdraws.
What's your name?
And the patient does it independently.
And juice.
So this study on melodic intonation therapy has been done in many, many languages by now, and meta-analysis has shown, of 22 studies, has shown that it has a positive role in improving trained and untrained phrases in patients with non-fluent aphasia or apraxia of speech. We showed the evidence in the Persian language. Following completion of my fellowship in behavioral neurology, I started working with Institute for Therapy Through the Arts in Chicago area. This institute is now more than 50 years old, and they've been very active in arts therapy and music therapy. I was able to kind of sit to see what they do in one of the memory facilities, and I was very impressed by how music worked for patients in groups. Their music therapists were planning the sessions, facilitating them, and then there was an ensemble who played for the patients. And then we decided to do a study to see how the music works, and then what does it affect in these patients. This is an example of one session of what's called the musical bridges through memory. So these are ensemble music interventions for people with dementia who are accompanied by their caregivers. So the idea for this intervention was to not only to enhance the quality of life of patients with dementia, but also to enhance the social engagement of these patients, many of which had apathy, and which was really affecting the relationship between the patient and the caregiver or the spouse. So we looked at 3 months of this intervention, once per week, to see how it affects the social engagement of patients, and then how much it actually enhances the caregiver burden. And we compared it to the control group, which received the regular care in memory facilities without the music. At that time, we had the privilege to be able to work with multiple locations for Silverado Memory Care. I used to be the director of one of them, but because they had the same structure, the control part was the same, and then we were able to measure control in one facility and then measure the music effect in the other one. And what we found was after 3 months of this intervention, so what we did was we recorded people on video speaking to their care partners before and after, and we measured. So Amy Carstens and Rihanna Schaefer, they measured the amount of verbal and nonverbal communication that the two had. For example, a patient with dementia might not have had any eye contact or engagement in conversations, and then after the intervention, that would improve. So what we saw was there was some improvement in total sociable behavior, and as you see in the control, it went down significantly, especially in the nonverbal sociable behavior. For example, being engaged in terms of body language, eye contact. Patients were significantly doing well if they were in the music arm. And the same thing we saw in the caregiver distress, and caregiver distress was much less, as you see in the music intervention group compared to the control group. We were able to secure a 3-year funding through NEA, National Endowment for the Arts, and we replicated this results so this was with about 30 patients. We were able to add another 30 patients to this study, which kind of replicated the same findings. And I put this slide just to show the structure of Northwestern Music and Medicine program, what we are doing here. We have an arm in the hospital, which we started about 5 years ago, but due to funding availability, it's been on and off. We are hoping to continue it more consistently from this year. This is for the hospital in general. We also work with the healthcare providers through the Northwestern Medicine Wellbeing Department. And there's the music interventions for neurocognitive disorders, MIND. And I'm going to talk to you about some of the programs and the research projects we have in this area. I listed 6 of them here, and then I'm going to get into the details of these. Before I get to the neurocognitive disorders, I need to give you a little bit of background about the work we did in the hospital, and then how that inspired us, or inspired our work with dementia patients. During the pandemic, we were able to secure some seed funding to work with patients in the hospital during the isolation. This was a disaster intervention technically. And our music practitioner, Ms. Clara Takarabe, played for the patients remotely through FaceTime. Our social workers would see the patients in person and then get a history of what type of music they liked, what type they didn't like. We had a music therapy consultant who oversaw everything. And we showed that mostly people were very interested and very pleased by, in terms of the emotional state after the intervention. They found it pleasurable. They found it decreasing their tension. The other thing we learned from that study was we had kind of an idea of what type of music each age range in the hospital they were interested in terms of classical, jazz, R&B, pop, or rock. So this kind of became some kind of a database for us, for our population at Northwestern Medicine. And we published it in 2021. One thing that happened that was very interesting was we had a group of patients who were connected to electroencephalogram, EEG. So we were able to look at what happened in the brain while they were listening to the music. Specifically, we were interested in patients who, for some reason, their familiar music or their preferred music was not working, or the nurses probably asked the music practitioner to play for them on the spot the same day, so there was no room for preparation. So what Clara did, she improvised for them. And then we worked on this improvisation and then kind of created a method for it so that it has something about a minute and a half to 2 minutes of musical statement interspersed by 10 seconds of pauses to create a calming atmosphere with a very slow tempo of about 60 beats per minute. And with viola, which was Clara's instrument, you have a range which is in the middle 2 octaves of piano, and then that range is what you usually use for calming. You don't use high frequencies, for example. So we were able to look at the EEGs for a group of patients we had in the epilepsy monitoring unit. And then let me show you how the music was. This is a press release from the paper, and then I'll show you some of the results. So what we did at the time, the music improvisation was about 40 minutes. We quite didn't know at the time how much time would be the best for this purpose. But we definitely knew that by 40 minutes, per Clara's observations, people were less fidgety, they were calmer, they moved less, they were, in terms of their outside behavior and facial expression, they felt much better. When we compared this 40 minutes to 20 minutes before and 20 minutes after, we saw an increase in alpha waves as compared to beta. So this is what you see here is the alpha over beta ratio, which, as you know, the alpha is occipital dominant. But then when we did ANOVA, you see the focus, the higher concentration of this happens in the front of the brain and in the mesial part of the brain, exactly those areas that I showed you earlier that are involved in emotion and social interactions. And then this effect, as you see, the post compared to the pre, it continued at least for 20 minutes after. We didn't look at beyond. But this was very interesting for us to be able to objectively show what happens in the brain. The other thing we looked at was we plotted the alpha over beta ratio, and then we saw that, again, consistent with Clara's observation, that people around 10 to 15 minutes into the music, they would get to the steadiest state of calmness without being fidgety or moving too much or being anxious. And then we saw the same thing around 15 minutes. They got to the highest concentration of alpha and then stayed until the end. And after which, the alpha wave decreased. So this is an example of how you can determine the dosage of music. So from then on, we thought, 20 to 30 minutes should be enough for us to be able to get an effect that we wanted. And then we thought, okay, this is very interesting. Can we use this type of intervention with what we call clinically designed improvisatory music in patients with Alzheimer's disease who have anxiety. I see a lot of them in my clinic. At least 40% of patients with Alzheimer's disease have anxiety, either because of the Alzheimer pathology or as a reaction to the fact that they don't remember things, and that puts them at a very stressful situation. So we proposed that to NEA, and then we got a 3-year support from NEA. And here's the structure of this study, which is really, phase 0-1. We have a delayed enrollment with a no intervention phase, evaluations before and after, and then an evaluation, and then the music starts and an evaluation after. And then before and after the music, we recorded fMRI, resting state, from patients or participants. The patients and caregivers went through 8 sessions of intervention, and because at the time, we were still coming out of pandemic, we designed it so that 4 sessions are in person and 4 sessions are on Zoom. And our primary outcome measures have been, this is an ongoing study, by the way, was rating for anxiety in Alzheimer's, in dementia, rating for anxiety in dementia rate. So far, we have data for about 18 patients, and then we've shown that there's a decrease in the anxiety level, which is quite significant. What was interesting, the effect of the music, the calming music, on autonomic nervous system, which we can show by decrease in blood pressure and heart rate and respiratory rate, that's been known for an immediate response to the music. But the question was, is there a cumulative effect after 8 sessions? And this is an example of a patient who, as you see, had a high blood pressure in the beginning. Every time he was anxious, he was had a very high blood pressure. And then as you see, the heart rate and blood pressure both kind of trend down towards the end. And we didn't even expect this, because this patient got admitted to the ED multiple times, into the hospital because of heart issues. But even with that, we saw some decrease in his autonomic reactivity and anxiety. I put one example of what we can see in resting state. We looked at many other networks as well, but this is an example of how the reward network, we had increased connectivity, again in the mesial frontal area and the prefrontal area, and the connectivity with nucleus accumbens as the seats. And as this connectivity went up, so this would be technically people feeling more pleasure from the music. And as this feeling went up, this correlated negatively with the anxiety. So the more connectivity, the less anxious they were. So this was nice to show some target engagement, and then also show that there's a correlation between our objective finding in resting state fMRI and our symptoms as they are measured by rate. So as this trial was ongoing, we thought it would be very interesting also to look at what happens in those subcortical areas that I showed you earlier, where sound and music is processed. Dr. Nina Kraus and Dr. Jennifer Krisman at Northwestern, the Brain Volts lab, they have worked on this for a long time, being able to record the auditory apparatus from the subcortical areas all the way to the cortex using a method they called frequency following response. So technically what happens is the participant listens to repeated syllables like da 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 da, or clicks, and then they record from the top of the head, as you see here. And what's fascinating is what's recorded in the from the EEG is really, it phase locks to the sound that they hear, and then based on that they can actually figure out what's happening before the stimulus, the signal is recorded from the brain. And by this way, we can find out the what the amplitude of this response is, what the timing is, and we know that in diseased conditions, for example, in somebody who had head trauma, or somebody who has gone through aging, somebody who has even peripheral nervous system problems like an auditory neuropathy, this can affect these recordings. For example, what was really relevant to us was they've shown that in people who are on the older side, there is a decrease in the amplitude of response, and there is a reduction in the speed of processing. And there was some evidence like this in mild cognitive impairment. There hasn't been really that many studies that have looked at this in the literature. And then this has been one of the methodologies that was recommended in the NIH Toolbox paper in neurology. And then we picked this as one of our outcome measures to look at the auditory changes in our CIMAC trial, where we look at the anxiety changes with calming music. What we hypothesized was because patients with dementia, they have a more complete or accurate decoding or encoding the sound. What gets to the cortex is more noisy, and it gets there with a lower amplitude, and the processing is slower. The question is, does music help enhance these? We thought that some of these changes can actually contribute to anxiety. Because patients with dementia, they have anxiety because they process the external stimuli in the world differently. There is such evidence in some elderly folks who went through some interventional studies, and Drs. Krisman and Krauss showed that they actually improved their timing precision, and then also their the amplitude of response in FFR. And then so that's what we've been looking at. We were very lucky that we got a pilot grant from the Music Dementia Research Network, and then that's an ongoing study at this point. We are recording from different patients. So far, we found that we have some data to suggest that this is what happens, that patients have a better processing of the fundamental frequency in terms of the timing and also the amplitude. But it's too early for me to show the results to you, so please stay tuned. The other study that we started with Caitlin Seibert, who at the time, a few years ago, was at University of Chicago, and also Mia Iliopoulos, who is the leader of the Greater Chicago Music Therapists, and also Jeff Wolf from Institute for Therapy Through the Arts, was to see if we can design a musical intervention that affects the emotional interaction with patients. Can we help patients with frontotemporal dementia with their lack of empathy? What happens in frontotemporal dementia is the patient is not able to reciprocate emotions, and that creates a lot of problems in the family. And this method was inspired by what has been done in autism, and we were able to show in 10 sessions there was an increase in interpersonal reactivity index in 4, and then we have another 5 fifth patient participants. So this is an ongoing study. We're still in the process of getting funding, and then looking at it at a larger level. Another collaboration we've been having here is with the Sounds Good Choir, which is a choir for older adults and patients with neurocognitive disorders here in Chicago. They have multiple locations, which allows us to look at a very large number of participants. One of the first things that we did and then we published was just to figure out exactly, and this is kind of to build upon what Julian Johnson has beautifully shown in her studies of the choirs, to see what are the things that people like about singing in the choir. What areas are they feeling better about? And then we found that out based on our questionnaires and then the open questions, that the emotional, social, and intellectual effects of music has the highest level in terms of what they mentioned in their questionnaires. And we had, in this case, this was a study that was done during the COVID pandemic. So this was a very unique situation where they became participants of the choir through Zoom. They were not singing together. They were recording their parts separately, which was very interesting. You can read it, more details in the paper. And then we had two groups in older adults and in the dementia patients. One group was sing-along, and the other one was where they would just learn the pieces and then perform in 3 months. And we showed that the patients in the choir, aside from the emotional and then social benefits that they mentioned, they really mentioned the intellectual stimulation and then the cognitive stimulation of the program, where patients in the sing-along, they liked the connection to past, they liked the familiarity of pieces, and that really helped them with their experience. Another program that we started during the pandemic, first on Zoom and then in person, was Musical Museum. The idea was to have a music appreciation session for patients, both for them to listen to the music and enjoy it, and also learn something. And even, these are patients with mild to moderate dementia, so they can still learn. It's not that they can't learn. And then even if they can't remember everything, the fact that they are engaged in kind of putting the music in context, knowing about some of the theoretical matters in music, that would be a cognitive stimulant, which can help them. I had a lot of patients in the clinic who were in many lifelong learning programs, and because of the memory issues, they could not keep up with their peers. So then I thought, it would be nice to have a program for them so that it's really attuned to their cognitive abilities. So this is a kind of disability-informed program where we have subtitles, we have disability-friendly location to have the music, the length of the concerts are slower and shorter, and then we have a reception afterwards. So we've done about 15 sessions of these so far, and per our surveys, the satisfaction, the pleasure has been high. The intellectual part, interestingly, is a little lower. As you see, it's still high, but lower than the others because they find it a little challenging. And this is okay because they do need the intellectual challenge. Otherwise, as you know, dementias can get worse without that challenge. And in general, the general feeling they had improved after each session. This is also what's called social prescription. This gives me and my colleagues an ability to check in with patients. And I may not be able to see them in the clinic every month or two, and it may take longer. But when they come to these concerts, I can check in with them. And this is what in UK, and then this is per the World Health Organization, has been known as the social prescription, where in environments other than in the clinic, you can check in with people to see how they're doing, so they don't end up in the emergency department. And for that reason, insurance companies like it. So this is another route that we've been taking here, and I know in some of the other states they've been very successful at putting this through, so insurance would pay for it. And just to share with you some future directions, the directions are the same directions as what NIH has recommended and MDRN is following. Our goal in general is to establish mechanistic evidence through rigorous science. And I hope that I showed you some of this kind of evidence through autonomic measures, through EEG recordings, and also through functional MRI network studies. We are working with MDRN now, with Dr. Pepe Contreras, to do more recordings of our studies here. For example, the anxiety study and the choir. We were very honored for them to be here last year to record some of these sessions, and we're going to have a workshop soon coming up by the end of July in Chicago to kind of demonstrate how this works. This is one of the goals of Music Dementia Research Network. And also to standardize interventions and outcome measures. Again, there's been a lot of work in this area. Folks in the music therapy world and also Music Dementia Research Network have been trying to show this standardization so that we all do the same thing and measure the same thing, so our studies are more effective and convincing. And for this reason, we do need interdisciplinary team to bridge neuroscience and arts. The Sound Health Network, what Dr. Johnson has done has been amazing and influential in this area, and then so is the Sound Health Initiative through the NIH, and the MDRN network in our case to kind of get us together, and so we learn from each other. I always learn from my musician friends and music therapy colleagues, and the other way around. And then we want to expand access through scalable and equitable delivery. For example, some of the programs we had on campus here, we've been trying to have them in other locations. We've replicated them in Wisconsin, for example, or in southern areas of Chicago where they may not be able to come to the campus. So we are making them available for them as well. And the top picture is the wonderful collaborations that I've had with the Julian Johnson, with Julian, with Dr. Pepe Contreras and his team. We've been doing a lot of advocacy here at Northwestern at the local level and national level. Our Dean of School of Music has been involved. Our president has been involved. So we are hoping to do more in this field. And then we started a music and medicine course at Northwestern that I'm hoping that we can continue to increase awareness among our clinicians, because that's not part of their regular training. And here's my collaborators, my lab members, and music and medicine members, and our supporters. And then we really relied on the work that all of these folks have done for us. Thank you so much. I'm here for any questions you may have. And I was told I should look at the Q&A. If you have any questions, please write them in the Q&A. So I think I can't see any questions on my side. I'm wondering if Dr. Johnson or Julian, if you see any questions?
I do not see any questions.
I think, yes. Okay. Well, thank you so much for your attention. And our information on social media, our emails are all here. If you have any questions, please feel free to reach out. Thank you very much.